Um, it is our honor and thank you very much to have all of you here with us. We are officially doing a product launch of the Insight system. And my name is Ellie. We are the distributor from MediLife for Malaysia. If you have any questions after these events, feel free to talk to us. We have our booth outside and we also have the demonstration kit. You can come and talk to us, myself or my team members. So without any further ado, I will invite William, who is our principal, to just have a couple of words before we pass it down to the first speaker.
Thank you, Ali. Good morning, everyone. It is my absolute pleasure to welcome you here for the formal product launch of the Insight system, so automated Chyme reinfusion therapy here in Malaysia. I wanted to extend my greatest gratitude to our guest speakers for coming from everywhere from Malaysia and also Singapore to share their experiences on using the device. The Insights company is a company from New Zealand. We're a company that was spun out from the University of Auckland, the School of Medicine. It was founded by colorectal surgeons and biomedical engineers with the goal to find a simple and elegant solution to manage patients with complex stoma and fistulas. Chyme reinfusion is not a new therapy per se. It's been around for quite some time. But it has been very cumbersome to manage manually in the traditional way. So our goal was to find design a device that was patient-centric, allowed patient to regain as much of a normal life as possible. And we're very, very excited to bring this to Malaysia to benefit more patients. And again, we're very grateful for our guest speakers for being here and being willing to share their experiences. And without any further ado, I would like to invite our first guest speaker, Dr. Hans Alexander from Johor Bahru.
Thank you, William. Very good morning. I'll try to keep this short. So my name is Hans. For disclosures, I'm actually an upper GI surgeon. And I predominantly do mostly gastric cancer and esophageal cancer work, but my unit also manages intestinal failure. So I actually have not received any money from these guys, I just checked. So I'm really here for free. I just happen to be covering Penang as well. So the good news is I had the pleasure of using the Insight systems for one of my patients, so I'm going to share a little bit of our experience. So as you probably know, that continuous reinstallation of Chyme and all that is nothing really new. Truth be told, actually, this was actually documented quite some time ago by Levi and such. But the problem is, it unfortunately, the problem is managing this. Most of your nurses will.
Put closer to you.
I see, so it's not really working well. My robotic voice does not carry. So the problem is most of your nurses will tell you that trying to take the small bowel effluent and reinfusing it is easier said than done, and if you try to put it to your junior officers in this modern day and age, most of them will complain. So the problem is, back in 1979, actually, they had already identified that if you do not reinstill the small bowel effluent, patients tend to actually be compromised nutritionally because the small bowel effluent actually is very high in protein and undigested fat. Also, at the same time, you're losing a lot of your bile salts and digestive enzymes, which were actually meant to be recirculated and recycled. So this is where Levy actually quite nicely wrote back in 1979 about how he tried to make the effort to take the effluent to actually reinstall it so that the distal bowel would not atrophy and die. Not literally die, but the problem is we do know quite a lot about the GI tract. Of course, the upper part is my interest, but the lower part actually is very, very interesting. It's not just about the absorption of water per se. You'll realize that a lot of your patients, if you don't actually have the fats going down, they tend to get a lot of oxalate stones. So patients who have short bowel, more than 6 months, be warned, you better do an ultrasound KUB because more than 60% actually get renal calculi. Our patient did as well, not this current patient. Carbohydrate and protein malabsorption is a major issue, truth be told. Hang on a bit, how do I make this bigger? Sorry, this is not my computer and I'm working with it. Yes, finally. No, don't stress. Finally worked it out. That's why I told you I don't like Apple. Damn you, Steve Jobs. But anyhow, so carbohydrate and protein malabsorption is one problem. You think that actually the small bowel can actually do quite a lot. Reality is not true. Fat and soluble vitamins. You will watch your patients lose hair with time and their skin degrade. While in male patients, it may not be so obvious, but your female patients will complain incessantly and moisturizers won't help. Bile acid is the main issue, and this is where you realize that the liver becomes very sensitive, the hepatocytes are overworked, and if you try to give parenteral nutrition to top it up, you realize that they tend to get a lot of transaminitis. So this is where actually my unit is an IF unit. We do quite a lot of work, and we've come to realize that we put in a lot of effort into trying to redo it. So the traditional way is to prepare the skin. My stoma nurse is smirking over there. She'll tell you how this looks good on paper, but in reality is a nightmare. And yes, you get something like this with that kind of three-way catheter, and then you use pumps. But really, to get this, it looks very nice in photographs, but it's not very friendly. It's quite smelly. Most patients don't feel comfortable. And trying to send your patient home to do this, I'm not quite sure who outside of Steve Jobs could probably do it. It is very messy. Tube blockage is a major issue because what caliber tube are you trying to use? And fecal material gets blocked. Labor intensive, you need to have dedicated teams. And dehydration still persists. Ironically, this is all our experience. So whenever you end up with this kind of polytrauma patients or colorectal surgery, unfortunately, advanced tumors, it can go wrong. This is where the elegant solution, which William has demonstrated, comes with the insides driver, the pump, and the tube. So this is poor Safwan when he wasn't so healthy. Although one thing I must say, he's always very cheerful. That's my trainee. These are my trainees, unfortunately, who, yes, they are a bunch of clowns. This is where the team actually participates. And yes, even during the procedure, they was calling for help. You have to prepare the tube. You need to get the pump. This is the driver, and this is the pump that actually goes in. Clean the stoma, identify which is the proximal and distal limb. You get the tube, size it appropriately, make sure the balloon works. The balloon is quite nice, doesn't burst easily, I can attest to that. And the Chyme reinfusion system actually takes the effluent from the bag and gently puts it back into the distal limb. And actually it does work quite well. Most of the time, the only problem is you need to make sure that the effluent isn't too thick. But if it is very, very thick, William will just tell you, add some water. So with that, this is how the bag should look with the setup. Let's see if the video plays. Yes, it does. So you can actually see that this is how the effluent, so you don't need to have the bag really, really full. We don't encourage the bag to be full, truth be told. Every now and then, when you get about half full, apply the driver. It's a magnetic lock. William will later demonstrate. And with this magnetic drive, it'll actually just churn up everything and gently pump it in. So here, you can't really see very clearly. We put the power setting at level 2 because it's a bit thick. If you put it too hard, too fast, the patient may feel discomfort, but otherwise, it's pretty all right. So this was a gentleman that actually was initially suspected of mesenteric thrombosis in a sister hospital, progressive weight loss and all that. Showed up, unfortunately, a bowel obstruction, underwent emergency surgery, extensive bowel resection, sadly, and it turned out to be actually typhoid. Surprise, surprise. So he had a horrible recovery and was managed by the surgical team. So this is actually a rather interesting graph. Bear with me, it gets better with time. You can see from September 24 all the way to July 25, so each marker is 1 month. And you can see where the ileostomy was done, insides was applied, and reversal of ileostomy eventually done. What we're going to concentrate is actually this green part here, because this is where it's interesting. So the red line here is calories from enteral nutrition, and the purple line is calories from parenteral nutrition. So during September, October, and November was the chaos that was being managed in the sister hospital. I'm not speaking ill of them. This is expected when you're having GI pathology. You can see that they were trying to initiate enteral feeds, were not able to continue. They had parenteral nutrition, so it's up, down, and up, down. And it was actually chaotic at that point in time. This is where he had recurring bouts of sepsis. The catheter was a problem with regards to parenteral nutrition. And of course, he even had transaminitis. Parenteral nutrition at this time was poorly administered. And when you really taper out, this is a man who's actually having active GI disease and his calories are not met, much less his protein requirement. This is where he was finally referred to us. And yes, it did not improve immediately. But you can see that, one, we actually had a stepwise approach. We could escalate the enteral nutrition slowly and de-escalate the parenteral component. because we actually were able to optimize his nutrition and overcome the sepsis. But this is where it gets interesting, because we knew that he would require some time before we could do the reversal of the ileostomy. His abdomen was hostile to begin with. So what do we do then? We couldn't really afford to keep him on parenteral nutrition completely. So this is where I had the chance to meet William, and he actually offered the system. And he did give it to me for free, which is why I'm standing here in front of you. So we actually managed to put in the enteroclysis system. Immediately what was observed was fluid boluses became unnecessary. His fluids actually really normalized quite well. Intermittently during parenteral nutrition, every 72 hours you need to give him fluid boluses. That's the funny little thing. Once insights went in, all that stopped. And we were able to slowly ramp up enteral nutrition and keep him parenteral nutrition free. And mind you, close monitoring was done. So this is where one of my friends calculated. So I actually asked somebody who works in private, how much would it cost? So of course in a government setting, we're heavily subsidized. Did somebody cough? Oh no, that's not me. Everyone thinks I'm going private. I don't know why. But PN costs about 1,000 plus per day on average. And a total for 18 weeks is going to set you back about 139,000. This is exactly based on the estimates, excluding line and excluding nursing charges and excluding other medications. This is just parenteral with vitamins and additives. So not bad actually, well done. How much does the system sell for? Have you declared it? Not yet. So he'll tell you how much it costs in the end. So I'm going to get scolded for this, but they don't pay me. So anyway, weight. So this is interesting. So Safwan's weight during the critical phase, you can see how much weight he loses and how. So you say his muscle mass didn't deteriorate. Safwan at that time didn't have much muscle mass to lose anymore, because if he lost it anyway, he'd be totally immobile. Fat collapses as well. So you must understand during the critical phase, looking at weight alone is not so good, but most importantly is we continue to monitor muscle mass, because sarcopenia does occur even in young men. This is where once we started to optimize his nutrition, we could build it up somewhat, but what really changed was this period. The insights really made him recover his weight and really recover muscle mass, and as a byproduct, somehow or other, Safwan got fat. So he's a bit upset about that. You all should encourage him to go to the gym. Sorry, Safwan, don't scold me later. I'm going to have lunch with him. But enteroclysis was able to do something that I can assure you with parenteral nutrition or enteral nutrition alone is not able to achieve. That's interesting, because immediately the restoration of his bile salts, enzymes, and such, the fat malabsorption actually really sabotages you over time. So this is where adaptation takes out. And this is Safwan in my clinic. You can see him in real life. Benefits above all else is full utilization of the patient's GI tract. You actually preserve water and electrolytes, and this I cannot emphasize, because this system really stabilized it, and I've not been able to achieve it without this otherwise. And it does protect a lot of micronutrient deficiencies, which actually are often overlooked. Safwan's hair, we actually do monitor these kind of things. Hand grip, muscle mass, and all that really improves. So in this, I must thank, although here we have identified a different boss, but the other boss is here today, so you should go ask her questions as well. But this is actually my team. I'm really, really humbled to be here. I don't deserve much of the credit. These are actually the guys who do all the graphs and all that, and I thank you so much for your attention.